All right, guys, I think we have everybody here. If you're having any trouble hearing me or anything, just let me know. Keep an eye on the chat for you. We're going to start off just running through the syllabus and kind of how the semester is going to flow. Like I said, if you have any questions, just give me a shout. As far as faculty, it'd be myself and Dr. Mordecai this semester. If you need to reach out to either one of us, email, text message, or fine. Email is a little bit better so we can keep track of things. We'll be meeting on Tuesdays and Thursdays from 10 to 12:30-ish. Lots of days we'll finish up early because you've got some outside classwork. A whole lot of fluff here in the syllabus. We'll get down to what you guys really need to know. So first thing, knock out your syllabus quiz this week. It's 1 extra credit point to your grade at the end of the semester. There are 3 main exams, and those are cumulative. And then you'll have exams in Maverick. And then in December, there's a clinical pharmacology exam. When you take that, if you achieve less than 90%, you'll have to complete a secondary pharm assignment. One of the things I want you guys to keep in mind as you're working through this is we're trying to make sure you're ready for clinicals. So things like when your clinical coordinator says you need to know your drugs on day 1, there'll be a test. There will be a test, and they may send you home, or it may be a rough start to your clinicals if you're not prepared. We'll get you the Maverick modules a little bit later on. Those are kind of a work in themselves, completing the modules. And then the 2 other assignments you're going to have, we're going to do symposium a little bit differently this year. In the past, what folks did was came and you spent about an hour putting together a care plan, and then you rushed through talking about it. You really didn't have a chance to prepare. You didn't have a chance to get everything situated. So this time what we're going to do is have you guys prepare the care plans during the semester. And then when you come to symposium, you will actually work through those cases. So that way you not only get to kind of formulate your plan, but you actually apply it as opposed to rushing through it and not really getting to think about things. There are also a series of 5 Anasoft cases to be done. I know several folks have gotten really motivated and already finished theirs. But that's just something else to kind of help you start formulating how to put together an anesthetic. As far as how the weeks go, we're starting off with week 1. I'll be going over x-ray principles and chest x-rays today. Dr. Mordecai is going to do radiology and laser safety continuing on Thursday. Next week, we're going to have a kind of open discussion / PowerPoint talking about conflict resolution in the operating room. Historically, that's been something that people have struggled with. Thursday, I'll be going over talking about burn care. On Tuesday of the following week, I'll go over some cardiac monitoring stuff. It's a little bit of review from what you've had, but it will also talk about some stuff like invasive monitoring, ASCDs, pacemakers, those sorts of things. And that will be the content for exam 1. For exam 2, starting on Thursday, you'll have Dr. Mordecai doing geriatric patients. The following week, you'll have hospital-acquired infections and antibiotics on Tuesday. On Thursday, you'll have exam 1. The following week, I'll go over skip and ERIS protocols and then PACU management and complications. The week after that, we'll talk about acute pain. That will be the end of that lecture series. Thursday, we'll start talking about immunocompromised patients. The following week, I'll talk about care of obese patients with exam 2. The following week, Dr. Mordecai is going to go over PONB and chemotherapy. And then after that, we'll kind of wrap up most of the standardized content and transition into Maverick, which don't underestimate the amount of work you're going to have in the Maverick modules. They can take quite a while. On week 9, you'll have your exam for all the other stuff. Remember, it's comprehensive. And then it'll essentially be a Maverick from then through symposium. After symposium, Dr. Schaefer will be joining you guys to talk a little bit about clinicals, how things work, rotations, prepare you for Typhon. We've got a little break in there for Thanksgiving, and then we'll come back and finish up with some pharmacology review, and then finally the exam for that. Are there any questions as far as the syllabus goes?
Hey, Dr. Cornelius, is Kenya. Question about the Anasoft. So are those due like the week or like the Sunday of that week or like that Thursday?
Everything should be due at Sunday at midnight.
Okay.
I will say, like, if you run late on stuff, it's kind of a reference for you guys. I don't want people procrastinating to the last minute. Like I said, there's several people that have already done all those. So they shouldn't take too long. And just a reminder, when you're doing those, you need to have a high pass. And all I need you to upload is just a screenshot of your log then. The biggest reason I put that in there is because we're actually going to discuss the cases in class. One of the things that's kind of frustrating for folks is you go through and do that. And there are some variations between kind of what we do in anesthesia and what the computer program is set up for. So we just go through and discuss. And that way, if you guys have questions about things, we can kind of explain it and help you guys understand what happened or didn't happen. So that's why the due dates are there. If you run late, I understand entirely, but just try and stay pretty caught up with it. Sound good? All right, we're going to look at, there's only one of the care plans that's uploaded right now for you guys to look at. The others will be coming shortly, but I wanted to kind of go over what I expect from that. And they're pretty laid back as far as basic expectations. I don't really care what format you use. The more important thing for me is that you understand the content and you're prepared. So when you get to symposium, it's primarily going to be focused on high risk, low volume scenarios. So for example, the first one we're looking at is an anticipated difficult airway. So what I want you guys to do is put it together in a plan, usually starting off with like an awake fiber optic intubation, and then 3 alternative approaches that you may use to secure the airway. So maybe wake the patient up, maybe put an LMA in, maybe do a retrograde intubation, maybe doing a surgical airway, things like that. So when you prepare that care plan, you need to anticipate the medications you would need to sedate and topicalize somebody for an awake fiber optic. And then when you guys get to symposium, you may not work through all of those scenarios individually because we'll be doing things in groups, but your group will work through those scenarios. So that way you guys can kind of work as a team, discuss things, but you also get a chance to apply all those principles you put together. But it's not like you're rushing at the last minute to be ready for it. So you'll have difficult airway, you'll have an intraoperative cardiac arrest, you'll have a maternal fetal hemorrhage or a traumatic hemorrhage, malignant hyperthermia. So things like that to kind of prepare you for stuff when you get to the operating room. Any questions about that? And like I said, paper-wise, I don't care what format you use. Just make sure you have all those considerations in there. So anesthetic plan, medications, and then you're prepared when you actually get to the scenario at symposium. All right, any questions? Perfect. So last thing, kind of housekeeping wise, we're going to talk a little bit about symposium. I know there have been lots of questions for things. Schedule wise, symposium itself is November 1st through the 4th. So Friday, Saturday, Sunday, Monday. You will need to be here or in town Wednesday night to start Thursday morning. On Thursday, you'll do things like mask fitting, any sort of respiratory requirements for that, for like PPD. Sometimes they need a physical, those sorts of things. And then if you need to reinsert your ACLS, PALS, BLS, we'll do that at that time as well. If you need to do it now, I know there's a couple people that are like working this fall and they were trying to get those restarted. If you send me an email, I can hook you up with a class. You also don't have to go through me. You can go anywhere else. We just try to put together a package and make life a little bit easier for you guys so you can knock it out while you're here. But there's lots of options for you. If you're working at a hospital and they pay for it, great. That's perfectly fine. As far as symposium itself, starting on Friday morning, we do a series of things. So the biggest one you're going to run into is that we do the Maverick cadaver-based regional anesthesia course. So you'll be broken up into 2 groups. Each of you will do about a day and a half at Maverick, and then we'll flip-flop. As you can see, that only covers 3 days. So usually on Friday, we start working everybody through scenarios, and then Maverick will be Saturday, Sunday, Monday. And that way everybody gets the most benefit time there without really getting overwhelmed. The remaining stations will go through and do central line placement on the mannequins, arterial line placement on the mannequins, these scenarios that I talked about in the sim lab. We'll also have what I call the airway playground. So we've got a series of things set up for you so you can do stuff like intubation on a salad mannequin, practicing with the video laryngoscopes, practicing with the fiber optic scopes. There will also be a chance for you guys to do some of the nerve blocks as well as spinals and epidurals, just a little refresher there. So that way, if you have any questions about anything, the people will be here to kind of walk you through stuff and kind of whatever we can do to make you guys as comfortable as possible before you head off to clinicals. So that's kind of the schedule. Usually we run like 8 to 4, 8 to 5 during the day. On Monday, we usually finish up about lunchtime. Not all the time. Sometimes it runs a little bit later, but that's kind of our goal, is to get everything wrapped up for you guys by lunchtime. I know there are people coming in from out of town, so that way they can fly out that evening if they need to. Something else I'll say as far as the schedule goes, there's a series of kind of fun things that go on. So the first thing is Thursday night. It just happens to be Halloween. So we're going to have a college bowl here. We're also going to have a costume contest to go along with that. So that'll be a fun trivia event for you guys. And then Friday, Saturday, Sunday, we have a social events sponsored by some of the anesthesia groups. And I'll get you guys those flyers as we get a little bit closer. But usually the way that plays out is they rent out a bar or restaurant, and it's open drink, open food, chance to talk to people, relax. Most of them are kind of large venues that have like outdoor areas, so it's pretty common to have bands, those sorts of things. But I know you guys haven't really seen each other in a little while, so it's a chance for you guys to kind of get back together. Just a reminder, you still got to be up in the morning. But any questions about symposium?
Hi, it's Caitlin again. I got a question. So that schedule, that whole schedule you were talking to us about, or when will we be getting that per se?
Which whole schedule?
For the symposium.
Probably a week or two before.
Okay.
Yeah, just plan on being here. I mean, you really can't go do anything else. But as far as like actual rotations, yeah, usually a week or two before. The problem is if I put it out ahead of time, I wind up having to change the staffing assignments because somebody volunteers to come and they can't come and those sorts of things. I can usually get you guys your portion of it earlier, but it's also subject to change depending on the university does something crazy and a building we were planning on using we don't have access to, or any of those sorts of things. The other thing that goes on that whole time is a series of recruiters and vendors will be in the Martin Center, where we're going to have the central line and arterial line stations this year. So if you're interested in talking to people about jobs, those sorts of things, that'll be available. And then the luncheons, a lot of times we'll have a speaker come in. They may be talking about transitioning to practice or job searches or any number of things. The other thing that happens, one of the anesthesia groups usually gets you guys a nerve stimulator. So at some point, I'm going to send out a list or a flyer to make sure you guys go on there and get them your information. Please do that. It's essentially $400 of free equipment that you're going to need. So putting in your name and email is kind of a small price to pay for that. Jessica asked, does the symposium start on the morning of the 31st or the 1st? Symposium starts on the 1st. But you need to be here on the 31st to do your pre-clearance requirements, so your mask fitting, health stuff, and then ACLS, PALS, BLS if you need to recert that. But symposium proper doesn't start till the 1st.
Will we be,
go ahead.
Sorry, will we be having class on that Wednesday and Thursday?
So for me, you won't be having class because at that point your class is doing the Maverick curriculum. As far as class for that Wednesday, they know you're going to be traveling, so you won't have something to do then either. It'll either be a recorded assignment or, taken care of ahead of time. It's not like you'll have to be in class. Leaky asked if there was any sort of dress code. For symposium, it will be scrubs. For Halloween costumes, just keep it classy, I guess is the best way to put it. Jackson asked, what time do we need to be there on the 31st? Dr. Kane will send you a schedule out with kind of the times. She goes through and sets up the mask fitting and all those sorts of things. So that's really the big schedule item we work through. As far as the ACLS, PALS, BLS, what'll happen, I'm going to send out an email if you need to recert those. I'll get you the test information ahead of time so you can do your exams. And then that day we'll just work through stations together. It's kind of low stress. We just work through scenarios, give you guys a chance to get a refresher in there, especially if you're going to be doing an intraoperative cardiac arrest scenario while you're at symposium.
Would you recommend us doing our research just so it's valid through like our whole clinical, even if we already have it, or just leave it be?
It's up to you. I will tell you, and this is Brian talking, this is not the university. If you expire, I'm happy to redo it at any point. It's just a little bit easier from a credentialing standpoint if everybody does it at one time. A lot of places will not credential you if you're expiring within 6 months or a year. So that's why we try and knock it out now for you guys. So that way you're pretty much covered for all of clinicals. So I can't tell you you have to do it here. Like I said, if you're someplace that does it for free, help yourselves. But otherwise, we try and make it as easy as possible for you. All right. Any other questions about the class, symposium, anything else that's going on I can answer for you? All right. We're going to hop over into chest x-rays. One other thing I wanted to tell you guys as far as class setup. So the way this will work, I record all the lectures. It will come out in a couple of different formats. So you will get an MP4 that's available to you. If you like watching videos yourselves, you can do it that way. The other thing I do, I know a lot of people like YouTube because they can speed it up or slow it down. So that'll be available to you as well. It does take a little bit after we finish class for me to get that posted for you. But at the bottom of the course modules page, there'll be a lecture recording place. And that's where I will put the MP4 as well as the YouTube link. So whichever one of those makes you happiest, you're more than happy to use. But like I said, the YouTube one takes a little while, especially for like a 2-hour lecture to get everything uploaded for you. For Dr. Mordecai, she's going to have a different Teams link because she won't have access to my recordings and vice versa. But she's going to do the same thing. I'll take her lectures, download the MP4, and put it up as a YouTube link for you guys there as well. So hopefully that makes it as easy as possible to kind of study and review things. There's one more thing I kind of wanted to show you guys on Canvas, just so it's available to you. So this is what the modules page looks like. I'm going to put it in the student view so you guys can see exactly what's available to you. So cooperate. If you need lockdown review, it's up there for you. All the exams will be taken on lockdown monitors, so you will need to have access to a camera as well as the lockdown program. Lectures will show up here. Sometimes there's just a PowerPoint. Sometimes there's some reading stuff for you. There's a lot of questions on boards that come out of this, so that's why we try and put as much information there as possible. The other thing you'll see is that a lot of this information is more clinically relevant and current than sometimes what you see on boards. So I may say something like the book answer is this, but this is kind of what current practice is, just because things lag a little bit behind in the testing world. So when you get to clinicals, you may be doing one thing, but the book answer that hasn't caught up with it yet is something else. So we're just trying to get you guys as much information as possible because you will run into a little bit of a disparity between current clinical practice, regional variations, and then kind of the board answer for things. So all your modules will be here. The other thing that's here is all the sim lab information. So as you start preparing for symposium, everything is here for you to go back and look at stuff. So if you haven't touched the laryngoscope in a little while, it's there for you. If you're thinking about putting together your airway plan, it's there for you. Thinking about fiber optic intubations, using bougies, LMAs, all those sorts of things. All the sim sequences are here for you. So if you need to go back and look, it's there. I'm trying to help you out with that if at all possible. All right. Any other questions before we head into lecture? Autumn said, can we use our laptop camera or do we need an external camera that connects to your laptop? No, I think pretty much everybody uses their laptop camera. I don't think you have to have an external camera at all. I'm not aware of that ever being an issue. And then one of the things I want to talk to you about as far as lockdown and the way it works, With the monitor, if there's an issue, it's not like it self-destructs and stops in the middle of your test. But what it does is creates a flag, and then I go through and review those for any sort of anomaly. So if you get up and walk rate 5 times, that's 5 different anomalies that have been generated. Just like anything else weird that happens. If it happens once, it's probably not a big deal. If you're walking out of the test every time, it's probably something we're going to have to discuss. Serena asked how much it'll be for the recertifications. It'll be $225 for ACLS, PALS, and BLS. All right, we're going to head into radiology then.
There's a question about which syllabus quiz are we supposed to take? Because there's like 3 of them uploaded.
Yeah, thank you for bringing that up. You can take any of them. I'm not sure why, and then people started taking them. So as long as you have taken one of them, I don't care. Syllabus quizzes are like a university necessary evil. I personally don't care at all, but they want it to be there, so it's there. As long as you do something that they feel demonstrates you participated in class this week, that's fine. I don't care. But I'm not sure why there's 3 of them there. I've gone through and deleted it a couple of times, and it just keeps pumping up. All right. Let me just share my screen real quick. Can you guys see that okay?
Yes, it looks good.
All right, perfect. It looks a little weird, but that's okay. You never know what is under people's clothing. So this is primarily focused on chest x-rays, but we're going to talk about some basic radiologic principles as well. Especially in your first 6 months of clinicals, x-rays are going to be one of the biggest learning curves for you. Historically, we've relied on the radiologist review of x-rays, so you may not have had all the information available to you. So it's kind of a funny picture, but the reason I put this up there, we take lots of x-rays, whether we're looking at central line placement, ET tube placement, trying to figure out anatomy, but sometimes we forget about what we may not see. Now, the biggest ones we run into aren't frustrations for us, it's usually for the surgeon. But think about your lines, think about your EKG leads, all those sorts of things that you don't remember are there until you start taking pictures, because it can quickly become kind of a chaotic picture for you. So just be mindful of that. And sometimes, in spite of doing the best you can, you still get surprises. Sometimes figuring out where those surprises are may be a little bit of an adventure for you. So just think about that. Sorry, I hopped through that. So things we're going to talk about today, chest x-rays and acute care. We're going to talk a little bit about the anatomy of the lungs and kind of how it plays into things, the normal structures we see on a chest x-ray. We're going to talk a little bit about different types of densities we see on chest x-rays. If you've looked at the PowerPoint on the back end, there's just a bunch of slides that have kind of different presentations for you. We're going to talk about a couple different methods for interpreting chest x-rays. I'll tell you further, but really it doesn't matter. Just have some sort of system as you work through things, because otherwise you wind up missing things if you hop around. And then we're going to look at some examples, like I said. So chest x-rays are obtained on almost every patient we encounter. Very few of our patients are true ASA ones where we don't have a chest x-ray. But almost anybody that's admitted to the hospital, gone through the emergency room, or have any sort of preoperative clearance will have had a chest x-ray done. If you're sending a patient to a pulmonologist, very rarely will they see that patient without them already having a chest x-ray done. So if you're sending somebody out for risk stratification or preoperative evaluation, that may be something you probably want to start off with. Now, it may already exist. I'm not saying you need to get a new chest x-ray, but if something has changed, you probably want to get an updated film. So that's one of the things that's really different about the US versus other countries, especially if you think about third world countries. They have very limited resources, so they only use them when they really need to. A lot of times they're more reliant on physical examination and history to make a diagnosis. The good news is chest x-rays are fairly cheap. There's not a whole lot of risk associated with them. The bad side is that you may find things you didn't know were there. which may be helpful. It may not be helpful. It may open a whole lot of can of worms for you. The other thing you see is that when we do true physical examinations of a lot of patients, that there's limitations to it. We can't see everything that's inside. There's also a lot of things that are very hard to differentiate. For instance, early onset pulmonary edema versus asthma. So a lot of times you have to think about the big picture there before you can make a true diagnosis. The other thing to keep in mind is a normal chest x-ray doesn't rule out stuff. For instance, asthmatics can have a perfectly normal chest x-ray and be in severe disease. So it's really a complement to all your assessment and everything else. It's not a standalone examination. Physical exam generally works a little bit better for acute symptoms. Chest x-ray is a little bit better for kind of chronic markers. So we're going to talk a little bit about things that cause problems for imaging for you. Exposure, for instance, can cause x-rays to be essentially illegible. If you have an x-ray that's overexposed, it may appear very dark. If you look at things like the bony structures, you may be able to see them very well if it's overexposed. But if it's something like the lung structures themselves or small nodules, you may not be able to see it at all. On the other hand, if you have somebody that's underexposed, you may have a film that's very white and you can't interpret anything at all other than maybe small pulmonary vessels. So you may think that you have somebody that has infiltrates when in fact they don't have any at all. Something else you see, and I put male and female, but it can just be a difference of tissue. Generally, one of the big things you see is breast tissue absorbs more of the x-ray beam, which will result in the tissues in the lungs being underexposed. But it just depends on tissue, the patient's body habitus, and positioning. This is just kind of an example of a chest x-ray that may be a little underexposed. If you notice, it's kind of white. So you may have what appears to be pulmonary infiltrates, but in fact, it's just an underexposure of the film. On the other hand, pretty decent picture here, but you see that you've got some breast tissue that's in the way. So when we look down on the bottom there, we may have a hard time kind of looking at the area right under our diaphragm just because of the location of the breast tissue. One of the other things you have to consider as we age a little bit, the location of our breast tissue tends to vary a little bit. So if you have somebody that's younger, the breast tissue may be very high. As they get older, obviously it's a little more lax, and it may droop down, obscuring your lung bases and your diaphragm. Something else to think about is how we get x-rays. So generally we obtain patients' x-rays in the outpatient setting by having them stand up with their chest against the film holder. The x-ray tube is behind the patient, so the beam is actually going to go posterior to anterior, or a PA. In most of our patients, we're getting portable chest x-rays, or even if we don't get portable chest x-rays, they may not be able to stand. So usually what happens is the plate will be behind the patient. So you'll get what's called an AP, or an anterior to posterior chest x-ray. It doesn't make a huge difference. The big thing that you see is that on an AP projection, it tends to make your heart a little bit larger just because it's further away from the film. And as that happens, the beam tends to kind of spread out a little bit as it goes further away from the tube. The other thing you'll see if you have somebody that's standing upright, gravity helps out a little bit with their lung volume increasing. So you may notice that they inspire a little bit easier. That allows you to see the lungs better. You get better visualization of the pulmonary markings. The other thing you'll see is that patients that are standing upright, things tend to drain posturally. So if you have somebody that has a hemothorax or a pleural effusion, they tend to run down into the costophrenic angles. So instead of having sharp costophrenic angles, you have blunting there, which helps you figure out that there's some fluid accumulation there. If you have somebody that's laying down or laying supine, they may not be able to breathe real well anyways. And then when you put their abdominal contents, their body habitus on top of that, it tends to push the diaphragm up into the chest. So you'll see that the lungs and heart are a little bit harder to visualize, and the pulmonary vasculature becomes kind of crowded. So think about that when you start looking at things. If you're able to get the patient to take a deep breath, that's great. If you're able to get the patient to stand upright, that's great. if you're getting a portable chest x-ray, always try and get it with the patient in the seated position if at all possible, just because you don't get a very good image with the patient supine. Just a couple of different images for you there. So as I mentioned a couple of times there, you have to think about what is going on with the patient when they take the picture. And part of it depends on the patient, part of it depends on the x-ray tech. So if you have a good x-ray tech, they tend to get the patient to do what you need to get the best image. If you have somebody that's just rushing to get stuff done, you may not get a great image. So a lot of times, especially if I have somebody sick, usually it's in pre-op or PACU that I'm getting chest x-rays, I hang out while they get the film because I know what I want to see, and I know that if I'm there, they're probably going to do a little bit better job of getting it. I can also try and make sure that I get a good inspiration picture so I'm able to visualize anatomy. And then I get an immediate result. I can look at the film right there on their screen as opposed to having to wait on it to get uploaded to PACS and then bouncing around a little bit. So just think about that. You can also, like I said, convey to them what you're looking for. If they have a little bit of guidance, they may get a little bit better picture for you. So there's a variety of systems out there. I'm going to give you a couple. You can pick whatever makes you happy. Just have some sort of systematic approach so you don't miss too many things. So this is one example. Works well for lots of people. There's another one after this. But AT-MIB, I will a lot of times start off down in the abdomen because when I'm getting a chest x-ray, the abdomen is probably not my biggest focus area. I'm getting a chest x-ray for a reason. It's probably to look at the chest. But there are some things in the abdomen that can tell us a lot. For instance, free fluid, abdominal distension. If I see somebody that's got a large gastric bubble, it may be a warning sign that they're obstructed or I'm about to get puked on. So those things may be helpful for you. After that, then I shift up to the thorax, move around looking at kind of the lung fields in general. Transition to the mediastinum, looking at the great vessels, the heart. Then I'll go through and look at each individual lung and then ultimately both lungs together. Here's another symptom for you. Abdomen, thorax, and then mediastinum, lung, if you're looking for a way to remember it. So lots of options there for you. There are some funnies in here for you. So if you need to laugh first thing in the morning. So as I said, I usually start off looking at the abdomen to think about what I'm seeing. It's generally less important for what's going on, but it's something I definitely need to pay attention to. There can certainly be some dangerous things found in the abdomen that I may miss. So just kind of use a back and forth pattern as you look at things. We're going to talk about some specific structures that you tend to see there. The big three things we're looking for are the gastric bubble and then the hemidiaphragms. And one of the big things you have to think about when you look at the gastric bubble is it present? Where is it? My hemidiaphragm should obviously be above my gastric bubble. But if you have somebody that, say, for instance, has a diaphragmatic rupture, you may see that the intestines have moved on into the thorax. So that may be a hint for you. You may see that the gastric silhouette is greatly enlarged. Start thinking then that there's probably a lot of retained either food or gastric contents there. So maybe this is somebody I want to consider RSIing. Other things to think about when you look at the diaphragms themselves, think about the positioning. There's something called the deep sulcus sign, where if you have a patient with a pneumothorax, not only does it compress the lung, but it will also depress that hemidiaphragm because it's forcing that down into the abdomen. So if you look at a chest x-ray, this is a normal variation here, but then you have a greatly decreased sulcus sign, you may realize that there's, especially in the setting of somebody you think may be a risk for pneumothorax, there's a possibility that they do have one. So then transitioning from there to the thorax, and when I say this part of the thorax, I'm really looking at the bony structures. So think about ribs, think about clavicles, think about the scapula, and I just work my way around. When I do that, things I want to think about looking for fractures, but really looking for symmetry as well. Even though I'm starting on one side and working towards the other side, it's kind of nice to have a reference there as I go back and forth for things. Follow the bones, make sure they appear to be intact. Rib fractures, especially small rib fractures, can be very difficult to detect on chest x-ray. It's a lot easier to see on CT. But one thing for you to think about, if you have a fracture of a rib, generally it's going to be fractured in a couple places. So if you locate one fracture, look until you find the other fracture. This is just an example of some things we kind of worry about looking at chest x-rays. So if you look, a couple things in the abdomen marked there, but you've got a little bit of kind of black underneath both lung fields there. That's a small pneumothorax where the air is not able to, or the lung is not able to expand all the way because of that air. Air will generally contour to whatever it's around. Fluid will generally become even. And what I mean by that is if you think about somebody that has a hemothorax and they're standing upright, generally you'll see that it becomes dependent. So these costophrenic angles here. Are you guys able to see my laser pointer okay?
Yes.
Yes.
Okay, cool. So these are the costophrenic angles here. Notice how it drops off. So these are what we call sharp costophrenic angles. Notice how they're kind of like a shark fin there. They're pointed. If you had somebody that had a hemothorax, for example, that fluid is going to be a lot more dense than the air. So it would almost take on the kind of the same consistency as the tissue here. So instead of being sharp or being visual, what you would see is that it continues all the way across here. So it's kind of level. It's going to fill in that gap. On the other hand, the pneumothorax is going to kind of contour to whatever's there. So you've got just this area of blackness here. Notice how your tissue stops right about here, and then you're able to see increased penetration there for the air. If you come over to this side, kind of the same thing. You're able to see that that air is there. So just things to think about there. Other things as you look up through here, as I said, check out your bony landmarks. You can look for fractures. They may be easy to see. They may be a little bit harder to see, especially if you start getting into areas that aren't as well developed. Like I can tell there's a clavicle up here. It's pretty easy to see. I can see that there's a scapula, but I kind of lose my superior scapulary border there. So just think about those sorts of things when you're looking at chest x-rays. Something else for you to think about as you start counting ribs is that because there are different places on the anterior and the posterior surface, it may be a little bit hard to distinguish. Usually if I'm counting ribs, I'm going to start on the anterior side and up at the top. So the first rib is usually superior to the clavicle. It may be almost impossible to see because usually the first and second rib are on top of each other. As you get down to the third, it's a little bit easier to visualize. And then obviously, as you get further down, there's less obscuring things until you get down to where you start to have the diaphragm or the abdominal contents that kind of obscure things. On the anterior side, it's usually a little bit easier to see. But what I usually do is just follow them all the way around and just make sure they're intact. You will also notice as we talk about lateral views in a minute that sometimes having a 2-view chest x-ray may give you a little bit better imaging than a 1-view chest x-ray does. So now moving to kind of the mediastinum, things we want to make sure we pay attention to there, the heart itself, as well as the great vessels. You may not be able to distinguish a whole lot on a normal chest x-ray, but if you have somebody that, say, for instance, has an enlarged cardiac silhouette or an aortic rupture, those things are usually pretty easy to see on chest x-ray. Smaller findings may be a little bit more difficult for you. But same thing, you're just going to bounce back and forth through the mediastinum looking for symmetry between one side and the other. So when you start looking at the cardiac silhouette, depending on which definition you read, usually if the cardiac silhouette is greater than a half to 2/3 of the thoracic distance, it's considered cardiomegaly. Some places will say greater than a third, but we've kind of moved on from that definition. So when you look at a chest x-ray, it's not so much an exact measurement as it really is kind of a judgment call. There is the ability with almost all the PACS systems to make a true measurement, but usually it's just kind of an oddball. You know, if you look at somebody and they have a big heart, it's pretty straightforward. It's not usually something you have to measure out there. But as you're working through there, make sure you evaluate all the great vessel structures. One of the issues you tend to run into is that a lot of those structures will overlie each other. So it may be hard to see things, especially if you don't have the greatest chest x-ray. So when we look at this here, I can make out the trachea pretty easily. I can make out the aortic knob. I can make out the heart. But as I get into this area here, it's really hard to see stuff. So I may not be able to distinguish my pulmonary arteries. I may not be able to see the carina, stuff like that. Techniques you can use to kind of ease identifying things. The x-ray will allow you to invert it, which basically means you're just going to change the contrast. And seeing structures that are difficult to distinguish on the traditional view may be possible by inverting it. So a lot of times the air-filled structures will stand out a little bit better. Most of the PAC systems, you can do that by either right-clicking or there's a setting somewhere where you're able to change things. And then finally, look at the lungs themselves. I don't care if you look at the lungs individually and then look at both. Just have some sort of system there. Things to keep in mind, the lungs are not the same. And if you do have that lateral viewpoint available, just remember that you do have differentiation as far as how many lobes you have on each side. And then just a lateral viewpoint for you. We don't get a whole lot of lateral views in our setting, and very rarely will you get them on anybody that's come in through the emergency room. Primarily, lateral views are done on outpatients as part of a preoperative workup or a pulmonary workup. This is another example of kind of a systematic approach for you. Like I said, I don't care what you use, just pick something that works for you. Start off looking at the bony framework, then transition to the soft tissues, the lungs, the diaphragms, and then ultimately finish up with the mediastinum, heart, and then the abdomen and neck. So this is a little bit different than what I have. It doesn't matter, whatever makes you happy. So kind of working through those bony approaches, start off looking at your ribs, follow those around, take a peek at your sternum. The sternum may be one of those structures that's really hard to see because it is in that mediastinal area, and a lot of times it's underdeveloped, so you may not get good perspective of it. But just something to think about there. If you have a lateral view, you may be able to pick out, especially in the thoracic spine, any sort of fractures or abnormalities there. Generally, if it's an anterior view, the only thing you can make out is down to about T3, T4. After that, it tends to get lost in the mediastinum. Most of our chest x-rays will be able to show us the C-spine quite well. Something else that it will show you, if you have a patient with narrowed airway space, you may be able to see it there. Obviously, if you have fractures or any sort of dislocations, you'll be able to see it there as well. Moving on to the soft tissue, as I mentioned before, pay attention to kind of problem areas like the breast tissues. They may obscure those costophrenic angles, so you're not able to distinguish problems very easily. I'll usually start off there, then move up to the area around the clavicle. Something for you to think about, just as I mentioned, if you have somebody that's upright, you tend to see fluid pool lower. If you have somebody that's upright, you tend to see air like a pneumothorax going up. So if you look up in the axilla, or up in the apex, you may be able to see those pneumothorax accumulating. Now, on the other hand, if you have somebody that has a pneumothorax and they're laying supine, it may really be difficult to make it out. A lot of times at that point, we have to look out to the lateral edges to be able to see it. And there's a couple of things we'll talk about here in a minute. If you have somebody with a hemothorax and they're laying supine, a lot of times it's hard to tell. It may just be kind of your whole chest x-ray is obscured. The good news is usually if we have a hemothorax, it's not on both sides. So you may just notice that layering on one side versus the other. When you're looking at the lungs themselves, there's a couple things you want to think about. So in the hilum, usually I start off in looking at the vessels. So if you think about the hilum, it's like the base of the lung or the root of the lung. So you should be able to see coming off the heart, the pulmonary arteries and the pulmonary veins. And if you follow those out, a lot of times you can follow what we call lung markings all the way out to the edge of the lung field. So for instance, that patient, we're concerned about them having a pneumothorax. You may start looking at your chest x-ray and I've got very good lung markings, but then I notice as I get towards the lateral edge that they not only are not visible, but I also have a black space kind of running down through there where that air is trapped. So lung markings may help you pick out pneumothorax. Now, the absence of lung markings doesn't necessarily mean you have a pneumothorax. It may just be an aid for you. Looking down at the diaphragm, things to think about, what are you looking at in the abdomen itself? So on the right side, a lot of times, as I said, it sits a little bit higher. Your liver's kind of a upslope here on the diaphragm. I think I said the left side. On the right side, your liver sits. On the left side, your spleen's there. Generally, the spleen's not quite as large, so it doesn't elevate that diaphragm nearly as much. Both of your diaphragms should really be kind of a curved or a dome shape. So as I mentioned, if you notice they're not curved at all, you don't have good visualization of that costophrenic angle, be concerned that there's either rupture of the diaphragm or some sort of a pleural effusion located there. When you look in the mediastinum itself, this is just kind of a breakdown for you as far as what you may see. Unfortunately, most of our patients, it's not this easy to see. The biggest thing I usually take away from looking at the mediastinum, as I mentioned, was visualizing the aortic knob and then the size of the cardiac silhouette. Transitioning from there to finishing up in the abdomen and then finishing up in the neck. Big things to think about, as I mentioned, the gastric bubble, looking for air under the diaphragm. One of the more common surgical emergencies we see is perfed ulcers, and a lot of times those ulcers are going to present as free air under the diaphragm. So when you're looking right down here, this is a normal gastric bubble. Notice how it's nicely curved. But what you'll see is that you've got diaphragm, and then you'll have air underneath of it. But as I mentioned, the breast tissue may obscure it right there. So maybe a lateral view is a little bit better. Other things to think about when you look up in the neck, a lot of our masses, like soft tissue masses, infections, those sorts of things will be visible on there. You may look at somebody's neck and notice that the trachea is greatly deviated by that mass or by something else that's going on. So just make sure you pay attention to that. This is just a nice slide if you're trying to figure out exactly what you're looking at kind of density-wise as far as comparing air, fluid, tissue, bone. There are some pitfalls we run into. The biggest one is either dependent on the technique or dependent on the patient. So if I ask somebody that takes a nice big deep breath and they don't do it for me, a lot of times what I'll see is that that diaphragm stays very high and everything inside those lungs stays very crowded. So I may not get a real great view. As I discussed earlier, over or under penetration can either obliterate or exaggerate specific findings. So just make sure that you get good technique. You're familiar with your x-ray techs. They do a good job. As I said, a lot of times if it's very important, I'll stand there and wait while they do it so I can make sure I get a good picture. Pay attention to your patient positioning. Just as though we don't get great x-ray techniques sometimes, the other thing we'll see is that they may just slide the plate behind the patient and take a picture. So be very mindful of how the patient's actually positioned. We've all seen that patient that was kind of curved over in bed, or they're like got the lean going or something like that. Try and get them to sit upright if you can. It's really hard for us to identify structures and exactly what's going on with the patient if they're rotated. Figuring out which lung is affected may be difficult. Figuring out normal versus abnormal anatomy may be very difficult. So try and get them to sit upright. Something for you to check when you look at that. Sometimes it's very apparent, but sometimes it's a little bit more difficult to see. So what you should see when you look at that is that the distance is almost equal when you go from the spine out to the ends of the clavicles. So if you notice that one side is a lot longer, they probably don't have some sort of weird clavicular defect. They're probably rotated. And then lastly, make sure you pay attention to how the x-ray was taken, just so you're kind of aware of how it could affect things like the size of the cardiac silhouette. So something else for us to think about is what's going on inside the lungs. And you'll see not only on chest x-rays, but when you actually get to the operating room, this is kind of important to know. Patients do have anatomical variations, but as far as the big things, most patients are pretty standardized. So just remember that on the left side, you only have 2 lung fields. On the right side, you have 3. You'll notice that the right upper lobe tends to sit very high. So particularly important if you're putting in something like a double lumen tube. If you happen to put that in backwards, so our left double lumen tube actually becomes a right double lumen tube, it's very easy to occlude that right upper lobe. So just be mindful of that. It can be problematic for you. And just a little bit of a different image for you. Our primary reference points as far as endotracheal tube placement when we're looking at the carina, generally want to be 2 to 3 centimeters above that. If you're not able to visualize the carina itself, a lot of times that 2 to 3 centimeters will be about even with the clavicles. So hopefully we get a great x-ray and we don't have to worry about it. But if not, you maybe use the clavicles as kind of a reference point for you. So this is just a drawing to remind you of what the lungs look like. And the reason we put that there is that they overlie each other. So if you have a lateral view, it may be very clear. But if you have an AP or a PA view, sometimes it's a little bit of a mixed picture for us as we're trying to figure out. So on the left side there, I've got the two lobes with the left upper overlying the left lower. On the right side, you've kind of got a wedge for the middle lobe there. So it can be kind of hard to figure things out. Usually stuff that happens in the upper lobe is pretty easy to figure out. Unfortunately, we don't see a whole lot that happens in the upper lobe other than pneumothorax. For instance, if you have somebody that aspirates, a lot of times it winds up down in the base as opposed to being in the upper lobe. This just gives you an example of what the lateral view of that right side looks like. So you can see how kind of that triangle middle lobe sits as opposed to the upper and the lower. The big thing for you to think about there is if you have something that's going on in this middle lobe, or perhaps even in the bottom part of the upper lobe, it may be difficult to differentiate between the upper lobe, lower lobe, and middle lobe. And there's just a picture of the lung tissue, the way it sits to kind of give you a reminder of that view. And kind of specific tips to think about for your different views. So if you've got a PA view, as I was saying, a lot of times you have extensive overlap, so it may be difficult to figure out exactly what you're looking at. The lower lobes tend to extend really high on the backside. So just keep that in mind, that that lower lobe isn't necessarily on the bottom. It may continue up well past the middle lobe into the part of the upper lobe. So lateral views are generally pretty helpful for that. All right, so let's see what it looks like on a chest x-ray. And there's kind of some highlighted images to help you break it down here. Usually on the right side, you'll see that the upper lobe occupies about a third of the right lung. On the back side, it's usually the first 3 to 5 ribs. On the front side, it may go as far as the 4th rib down. This is a lateral view, kind of gives you a little bit better perspective of it. Middle lobe. So you'll notice on this view that it's a little bit different than that triangle that I talked about when we transition to the lateral view in here in just a second. It's a little bit more of that triangular view, but you can see how on this patient, the upper lobe and the middle lobe essentially occupy the entire right side, and we haven't even brought the lower lobe into play. So the lower lobe on this patient really takes up a big portion of the posterior as opposed to being a true lower. Here's the smaller middle lobe that I was talking about. You can see it kind of maintains that triangular shape. And then here's that lower lobe. So when you think back through that patient, upper lobe, about half, middle lobe, about half. And then that lower lobe takes up about 2/3 of the patient's right side, even though it's all sitting posterior to that upper and middle lobe. So if you think about somebody that's aspirated, or somebody that's got maybe fluid or pneumonia or something like that, it can be kind of hard to tell from the anterior view. The lateral view may give you a best perspective. Something else you'll see is a lot of times these patients have very good correlation with clinical exams. So you either percuss an area or you listen, and by doing that, you're able to pretty clearly tell where the problem area is or the pneumonia, which is the most common issue we deal with, is from that perspective. And these are just showing you the fissures that kind of separate those things out. Transitioning over to the left side, it's a little bit easier picture. The left upper lobe basically covers the whole anterior surface. On the anterior view, on the lateral view, you can see that it's divided pretty evenly between the upper and lower. And again, you only have one fissure on the left side, 2 on the right. Just a little view of generally where things sit from a cardiac standpoint. This is really more academic than useful. Most of our patients were not able to distinguish that. You know where things should be, but you may not actually be able to see it. And then this is here a lateral view showing the different fissures, as well as kind of the cardiac spaces, this area behind the sternum. So we're going to talk a little bit about some common X-ray signs that you may hear mentioned. So silhouette sign's the first one. And what happens here is that if you have somebody where the heart or the aorta isn't kind of in line with something, it may obscure that. So you may not be able to distinguish things very clearly. An example would be looking along this boundary line right here. Notice how there's this little black line. So that may be a silhouette of the heart. Other things that we'll commonly see around the mediastinum, we may have air accumulations for pneumothorax, but remember that a little bit of a black line there is normal. It's that silhouette sign. It may not be a pneumothorax. It may just be the silhouette of the mediastinum of the heart that's causing that black line. So that's what I'm talking about kind of right here. And then you can see it again over on this other side. I've got a picture in a little bit where we'll see some air around the heart itself. Another common sign is the air bronchogram sign. So usually what we see on a normal chest x-ray is we're able to identify the trachea and the proximal bronchi because they're filled with air and the soft tissue around them is a little bit different. You usually can't see the lungs because the air density there is a little bit different than the alveolar air visualization. If you look at the air in the intrapulmonary bronchi, you may see what we call that air bronchogram sign. And basically what that's showing us is that for some reason, there's something other than that normal lung tissue sitting around it. So it may be a mass, it may be an infiltrate, it may be an obstruction. So you normally should not be able to see the bronchi on the lungs. So if you do, start thinking that there's a reason that may be problematic for you. All right, we're going to pause right there, let everybody run to the bathroom, and then we'll come back in 3 minutes. All right, we're going to pick back up and kind of put it all together, just looking at general x-rays. So just things to kind of think about as we work through it. Like I said, starting off with the abdominal structures. So gastric bubble, left diaphragm, right diaphragm. Good costophrenic angles visual on both sides. Working through my bony structures as I go around, I don't really see any sort of variations I'm concerned with. Coming back to look at my lungs, starting on the right side there, I can see things pretty clearly. I've got lung markings going all the way out. One thing I didn't mention earlier, sometimes you'll have trouble seeing your lung markings because of the scapula. So you can see how the scapula kind of runs right through there. It may obscure part of your lung markings there from time to time. So just be cautious with that. When you come around the other side, same thing. The scapula kind of includes part of my lung markings there, not really a big deal. And then working up through the middle, I can see my vertebral bodies laying in the background. It's kind of unusual to actually be able to make out the intervertebral spaces from an AP view, so that's kind of cool. Cardiac size is not real great. Not worried about that. I can kind of see my carina here. The image quality is not real great. I think part of that's just the computer, though. So we're going to talk a little bit about densities and kind of pathological processes and how they affect things. So a lot of times what you'll see is that in most disease states, air winds up replacing the air is lost to whatever the pathology is. So say, for instance, you've got that hemothorax. You'll see that your airspace has been lost to fluid, or you lose airspace to tumor, stuff like that. The good news is it's generally a fairly predictable response. So after you get to where you can kind of identify things on chest x-ray, you may not know exactly what it is, but you can identify the process. And what I mean by that is if I realize there's a pleural effusion, I may not be able to identify if it's a hemothorax or a chylothorax, but I recognize that I have fluid there. Same thing with metastatic processes. I may not be able to identify what type of tumor, but usually tumors are pretty identifiable. And I don't want you guys to worry so much about the details, is like I said, kind of starting off with the basics there. What is that density I'm really looking at? And this is just an example of some of those things I was just talking about there. You may see that you have kind of widespread processes throughout the interstitium, throughout the alveoli. Pulmonary or vascular issues may be pretty easy to make out, or it may be a little bit more of a localized process. So like a right middle lobe infiltrate that's consistent with pneumonia, a cavitary lesion, a mass, those sorts of things. So just we'll look at some of those as we kind of work through things. So this is an example of consolidation. And what you see here is that the alveoli get filled up with some sort of inflammatory exudate. And when that happens, it can be a variety of things. It could be white blood cells, it could be bacteria, plasma, or most commonly it's debris that then leads to those other things. So you'll have some sort of aspiration, and then you have an inflammatory response to it that consists of the bacteria, the plasma, and the white blood cells. Pneumococcal pneumonia is the most common cause of lobar consolidation. And there's a couple different stages there that result in the buildup of secretions in the airway. But generally what you're going to see is that you've got some sort of density that's consistent with a segment or a lobe. You usually don't lose lung volumes because the lung is still there. The exception to that is if you get to the point where you've got a inflammatory process that includes a distal airway, or maybe even like not necessarily a main bronchus, but perhaps a terminal bronchus. So think about like a mucus plug. At that point, you may lose a little bit of lung volume, depending on the state when it was occluded. So for instance, like if the patient had inspired, you may have a nice big lung. If they were expiring when it occluded, it may be a lot more limited. And this is really a better view of it. So this is kind of that triangle picture of the right middle lobe. So if you think about somebody that's aspirated and it's just affected this right middle lobe, it's pretty clear to see. So I've got upper lobe, I've got lower lobe, and then I've got that right middle lobe infiltrate. or the consolidation. So when we pop back over here, it's kind of hard to make out that picture. But when I come this way, it's a little bit easier. Atelectasis can be kind of hard to differentiate sometimes, especially if you've got a poor quality image. But basically what happens with atelectasis is you've lost air for some reason. So you've got some sort of obstructed lesion on the bronchus itself. And when that happens, there's no ventilation beyond that. So this is a little bit more that picture that I was talking about as far as like a mucus plug or something like that. But this is a more chronic condition as opposed to the mucus plug being a little bit more of an acute condition. What will eventually happen, the pulmonary circulation is going to absorb that air. And as that happens, you'll see that the lobe becomes really devoid of air and develops that atelectasis. So you'll have actual volume loss in those patients. The other thing you see is on the normal side, you'll have a little bit of a hyperinflation to make up for it. So you may see increased volume on one side to compensate for the lack of volume on the other side. Again, generally follows a lobar process. So you may notice that it, for instance, in this situation, it appears to be a little bit more of an anterior process. Things you can do when this is going on, if you don't have the opportunity to get a lateral view, go back and look at other imaging sources. A lot of times stuff like a CT will help us out. Even the scout film on a CT oftentimes will be better than looking at a chest x-ray. So when you're thinking about abnormalities, there's, again, kind of a process you can work through. First of all, figure out where the abnormal processes are. Think about how you can localize it. So think about like lobar processes or vascular structures, those sorts of things. And then work towards actually identifying what the pathology is. After you figure out that pathology, think about how it happened. Pneumonia is kind of a straightforward process, but what led to the pneumonia? Was it swallowing? Was it patient aspirating under anesthesia? Things like that. Just little things that can kind of come into play. If you have a very complex picture, a lot of times it's going to be away from us as far as like diagnosis and interpretation. But this is kind of the process that they usually follow. Usually they're going to get a CT. If it's something that's involving vascular structures or something they're having a hard time seeing, they may use contrast. But usually it's going to be just a CT of the chest. If it's something like a mass, they may wind up getting an MRI to help differentiate, and then ultimately a biopsy. If it's something like an aspirate or a straight pulmonary issue, they may do a bronchoscopy, they may do a biopsy, they may take a pulmonary aspirate to help them identify not only what's going on, but how to treat it. So a couple things to think about. And one of the probably most important things for us is the location of our endotracheal tubes and lines. So when we look at a chest x-ray, we have that systematic approach, which is important. We never want to skip through that. But if I'm primarily trying to figure out where my endotracheal tube went, I need to focus on these three structures really. So the biggest one is going to be the location of the carina. This chest x-ray, you can see it fairly well right here in the middle. But a lot of times you'll look, and the easiest way to figure out where your carina is to follow your right up, follow your left up, and then the location where they actually meet. Again, as I mentioned, you may be able to use that inversion view to figure out where your endotracheal tube is, or you may also be able to just use the location of the clavicles as a reference point. So if you think about your carina being here 2 to 3 centimeters above, is probably about even with your clavicles. So this is another example. Looking at this patient, a lot of things going on here. So we're going to kind of work through it systematically. I just zoomed in on it because it was kind of hard to see. So what do you guys think this is coming in on the left side? What does that look like? So that's a central line going in through the subclavian. Up here, this is probably our ventilator circuit that's sitting over top of the patient. So circuit, that's probably the HME. So then we're going to look at the endotracheal tube itself. So looking in the trachea, which is hopefully where endotracheal tube is, I'm able to see the trachea itself, and then it's got this radiopaque line that runs down the tube. And I can follow it down. Looking at the magnified view, I can find the tip of it there. Here's my carina. I can measure if need be, but that looks like it's probably a good position. Coming up above, location of my clavicles. So I'm pretty happy with that for the most part. Other things that come into play, this is probably a gastric tube coming down. You can see it laying over here. As far as determining the location of gastric tubes, just be very cautious. We get in the habit of just deciding it's below the diaphragm, it's probably okay. But if you're going to be feeding somebody or giving something by that gastric tube, just be really cautious. You do increase the aspiration risk. Something else for you to keep in mind from an anesthesia standpoint, usually if we're putting those in the operating room, it's somebody that's got an intra-abdominal case. Always get the surgeon to check placement for you. They'll be able to actually feel where that tube has wound up down in the abdomen or in the stomach. Something else for you to think about, if I put an endotracheal tube into the esophagus, what does that look like on chest x-ray? Any ideas? So the downside is if I put an endotracheal tube in the esophagus, it looks just like one in the trachea because they're both midline structures, right? So just be very cautious. Hopefully you figure it out before you get a chest x-ray, but it's not helpful at all as far as determining location. You may figure out that you're in the stomach, but you're not going to know you're in the trachea versus the esophagus. So this is a pediatric patient. Same thing, we're following our endotracheal tube down. So as I look, here's my ET tube coming down. This is my carina right here, and then my tube goes all the way into the right side. So I've got a well-oxygenated and inflated right side, but then I look over here at the left and notice how I have no lung markings at all. That's because I'm not ventilating. So with kids especially, this is kind of a common occurrence, and part of it's just that, like from a physical distance standpoint, there's a very narrow margin of error between good placement and being generally right main stem. It can be left main stemmed, but it can be as little as just flexing or extending the neck. So be very cautious with that. Be cautious when you move your pediatric patients. A lot of times I'll put my hands under their head and hold their head and torso together as I move them, so this doesn't happen. Be very mindful of placing endotracheal tubes on patients. With adults, we tend to get in the habit of just pushing it in there. With kids, you really need to pay attention and make sure you're not going too far past the vocal cords. Other things to pay attention to, breath sounds are good, but you may notice, especially if you've got a small child, that your breath sounds may refer from one side to the other. So put your hands on their chest, feel. Something else that may be helpful for you is paying attention to your airway pressures. So if I put a tube in there and my initial airway pressures are like 10, and then on the back side of the case, the patient's sats are going down and my airway pressures have gone up quite a bit, check that tube position. Make sure it hasn't migrated on you because that could be the problem. Another thing we have to pay attention to is our lines. If you're putting a line in there, you're responsible for its location. In a perfect world, the catheter tip should sit between the kind of the proximal valves, the subclavian or the jugular veins in the right atrium. If our line is extended all the way into the right atrium, we may be a little deep. Even if you're doing CVP measurements, you probably don't want it quite that far in. But this is somebody, the chest x-ray is not real great, but we can make out the line placement pretty easily. Something else for you to think about here, if I look, notice how his spine is here and his sternal wires are here. What does that tell me? Shouldn't our sternum and our spine sit over top of each other? Yeah, so he may be a little bit rotated. So be cautious determining line placement on somebody that you don't have a very good image. Here's a little bit better image for you. Notice our sternum and our vertebral processes are basically symmetric. The downside is that this IJ line is probably a little deep. So when I start looking here, here's my line coming all the way down. I've got a gastric tube that's coming down, endotracheal tube sitting here. But this line is probably almost all the way in the base of the right ventricle. So in reality, it should be up here somewhere. So what do you think you would see from a image or from a cardiovascular standpoint with this? You're probably going to have some ectopy. The catheter tip down there tickling the ventricle is probably not real good. So here's another picture for you. This is showing that the tip is actually sitting all the way up in the external jugular vein. You want to make sure that you follow it all the way down as opposed to sitting all the way up there. So just be very cautious with your line placement. This is kind of a problem area for us. You will also see that these catheters do all sorts of extreme things. A lot of times they'll come down and they may wind up going out in the zygous vein. They may curl up and go back out the other IJ, out the other subclavian. Any number of things that don't entirely make sense will still happen. So anytime you put a line in, get a chest x-ray. Other things to think about when you're putting those lines in, especially at first, you may want to get in the habit of transducing them before you dilate, because a lot of times the IVC and the or the artery will look the same. Not IVC. The internal jugular and the carotid will look the same. So just be cautious with that. You want to try and avoid dilating carotids if you can help it. It's bad for your patients. This is an example of a pleural effusion. So on the left side, notice how you've got kind of that crisp costophrenic angle. Over here on the right side, like I was talking about, you have that fluid level there. There's no costophrenic angle here at all. And then when you transition to the lateral again, you've got a pretty clear view. This is a patient with right middle lobe pneumonia. So as you look over here on the right side, you can kind of make out that pattern. Like I said, if it's a lower lobe, a lot of times it will follow all the way down to the base. Notice how this stays up high. So if you had a lateral view, it might be pretty clear to you as far as where that pneumonia is sitting. Patient with a right upper lobe pneumonia. Again, that's pretty straightforward. This is a patient with a right lower lobe pneumonia. See how this goes all the way down into the base here? And then when we look at the lateral view, we're able to see that it's kind of sitting posterior. There's a random head in the middle of the x-ray screen. The reason I put that up there, be very cautious when you're getting x-rays about where you're positioned. Especially with kids, we have this habit of trying to help them remain still by holding them. You don't want too much radiation in your life. We spend a whole lot of time in the operating room getting radiated. Wear your lead, be careful. We're noticing, especially in proceduralists like IR and cath lab, there's an increased incidence of cataracts. So a lot of those folks have gone to wearing lead glasses. Just something for you to think about there. This is an example of that free air under the diaphragm that I was talking about. So you're able to see your diaphragm here pretty clearly. You can see it here pretty clearly on both sides. And you see this line of air here. Obviously, that's somebody that's upright. The air is tracked superiorly. So those are the people we start thinking about gastric rupture or some sort of ulcer that's perfed there. So this is an example of a cavitary infiltrate. A lot of times what we see with these is that it's a loculated infiltrate. So perhaps this is somebody that's aspirated and now it's walled off inside that chest. This is what's called a Gone complex. And this is kind of the classic lesion for TB. The good news is we don't see TB very often anymore. The bad news is that it's starting to make a comeback and we're starting to see that it's becoming resistant to a lot of the treatments. So as opposed to here where we kind of had one lesion, you'll notice here we have multiple lesions throughout the lung. So just be very cautious when you get somebody. One of the big things for a lot of these things is that you recognize there's something weird with the chest x-ray. As I said before, you may not be able to figure out the pathology exactly, but recognizing there's something strange here, something that shouldn't be there, and then getting them to somebody to kind of evaluate that a little bit further. This is a large mass in the mediastinum. So we look down here, we've got a normal cardiac silhouette, and then as we start tracking up here, we notice there's something. One thing I would be concerned with this patient, I'm not able to see their aortic knob very well. So when you have something like this, think about their presentation, anything else that may be going on, because that could be aortic rupture as well. So just keep that in mind. If I had somebody that was kicked in the chest or car accident and I saw this, I would be concerned that they've either ruptured their aorta or their esophagus and have kind of a wide mediastinum there. This is a mass in the left upper lobe. Notice how it's kind of unique there. This is a patient with multiple metastatic disease. Started off as testicular cancer. So you notice you've got a Mets here, you've got a Mets here. Other things to think about when I look at this patient. What's this? So that's going to be a portocath. What's this? They've had some sort of neck fusion. So little things like that that may not be the reason you got the chest x-ray, but may be important. The other thing, anytime you order a test, whether it's a CBC or chest x-ray, you're responsible for the findings on there. So maybe I ordered this chest x-ray in recovery because we put a port in and I wanted to make sure he didn't have a pneumothorax. And then we figure out he's got these masses that I didn't know were there. Or maybe he's got a pneumothorax. or maybe he's got TB. Make sure if you get a test that you follow up on it. So obviously I'm not going to be the one treating his cancer, but I want to make sure he's got a referral to his PCP. It doesn't get lost in the system. Depending on your system and kind of how it's set up, the process is handled differently. Sometimes it's a matter of a simple phone call or a message to the PCP. But if I have a critical finding like that, I'm probably going to call him personally just to make sure it doesn't get lost. This is widespread pulmonary metastasis. Obviously, it's not anything new. He's already got a port in place. He's being treated. Sometimes x-rays aren't a surprise at all. They just confirm what we already know. So this is a patient with pneumomediastinum. So this is a little bit different than that cardiac silhouette or the air silhouette we were seeing earlier. You can make out air kind of around the heart there on both sides. This is a patient with a pneumothorax. So if I look over here on the right side, notice how my pulmonary markings come all the way out to the side. On the other hand, when I come to the left side here, I've got a very sharp line that cuts all the way down through there. So I can make out my pulmonary markings here. But then over on this side, I've got a really dark area. Remember, dark is going to be air. So that's going to be a pneumothorax. This is just kind of a magnified, view of what I was just showing you. This is a patient with subcutaneous emphysema. So a couple things that kind of pop out at me here. One, this pattern here on the soft tissue is very classic for subcu emphysema. And notice how it's everywhere. It's throughout the chest, it's throughout the neck. Again, this is usually not a surprise. Very rarely is that going to be our initial diagnosis of subcu emphysema. But what we do see is that it's probably got some other stuff going on here. Decent sized heart. When I look at this diaphragm, that's a little concerning to me. Remember we talked about generally it's kind of a nice curved dome. This one looks like it's a little bit depressed. We're going to look at an example here in just a second that's a little bit more clear for you. But just be very cautious when you see somebody that's had enough force on their trachea or on their pulmonary structures to wind up with subcutaneous emphysema. There's lots of times associated pneumothoraces. This is an example of that deep sulcus sign. So if you look over here, got a nice kind of curved dome. Over here, this is actually going to be gastric silhouette. Notice how there's air there. And his diaphragm has been pushed all the way down there. It's kind of hard to see because you've got overlying structures, but this is actually the diaphragm way down there. So again, think about patients with pneumothoraces at that point. So we will wind up with lots of foreign bodies inside of patients. Sometimes they're supposed to be there, sometimes they're not. Just be very cautious with that. That may be why they're here to see us. It may not be. This is an example of a nail that wound up in somebody's chest. Sometimes we put those foreign bodies there. Sometimes it's like a guessing game to figure out what's where and how it got there, and is it supposed to be or is it not supposed to be. Common ones we run into outside of devices we place: snaps on gowns, belt buckles, EKG leads. The ER can slap EKG leads on somebody like nobody's business. So you'll see that you think you got all the electrodes off, and then lo and behold, there's another one. So just be cautious with that. Likewise, if we have somebody that's going in for a procedure where they're going to be turned prone, we'll commonly put new leads on because we don't want them laying on those for hours. Make sure you take the old ones off, not only because it's uncomfortable, but because they're going to be getting films. And without fail, that x-ray is going to wind up with a lead right in the middle of someplace we need to see. So just take all the electrodes off or put them in the right place to start off with. We also get foreign bodies. If you're anywhere near kids, they tend to swallow things. One of my kids had a coin that fell into his mouth while he was asleep at daycare, and somehow he swallowed it. The good news is that most of those coins will wind up going down the esophagus, and they usually pass out pretty clearly. When you look at a coin, there's a couple different ways you can kind of tell where it is. So first thing is look and see if it's midline. So if it's midline, it could be in the trachea or it could be in the esophagus. Usually, if it's gone lateral, it's either gone into a bronchus or it's gone all the way down into the stomach itself. So when you look at somebody, the kind of C-shaped cartilage faces the back of the trachea. So if you have somebody that swallowed a large coin, it's almost always going to follow the path of least resistance and go down to the esophagus. So when it gets down in the esophagus, what will usually happen is it's going to sit flat against the kind of the C-shaped portion of that trachea. So when you take an x-ray, it's going to look like it's kind of sitting towards the bottom end of the trachea, but it's usually going to maintain that position in the esophagus and get wedged. The other thing, look at the patient, see how they're presenting. You will have patients that have difficulty breathing because if I have a coin that's stuck here and I can't breathe because it's partially compressing my trachea, it may be hard to tell if it's in the trachea or if it's in the esophagus. What usually winds up happening is that we're going to take them to the operating room and go down and look and see. But usually if it's in the trachea, instead of being held up this low, it's probably going to be a little bit higher up. Not all the time, though. It also depends on the size of the coin and the size of the kid. So thinking about our chest x-ray principles, where's the most likely place for it to get held up if it makes it past the vocal cords? At the carina, right? So where did we talk about the carina being? So I can see right sides coming up here. I can see left sides coming up here. So it's probably sitting a little high for the carina, but that's not a for sure. It could be stuck in that C-shaped cartilage. So sometimes it's easy to tell, sometimes it's not. This is just kind of an example of what I was talking about with that coin and the trachea itself. This is a patient with pulmonary fibrosis. So if you think about it, it's very similar to that subcutaneous emphysema pattern we saw on the chest x-ray, except it's just affecting the lungs. Usually these patients will have either a work history of some sort of pulmonary exposure, working in coal mines, working in auto parts stores, something like that, that's to help them develop that pulmonary disease. X-ray techs are kind of fun to mess with sometimes. So this is an example of widespread pulmonary edema. As you see, there's nothing like clearly identifiable that you would think of like a pneumonia, like a localized infiltrate. It's affected all the lung fields here. Other things that tend to go along with that, you've got a very large cardiac silhouette, so you can understand how the patient probably wound up with their pulmonary edema. Depending on the extent of the pulmonary edema, it may be very difficult to visualize underlying structures. So like here, I can kind of make out costophrenic angle. Here, I can't. I can't really see ribs. There's some sort of, it looks like maybe a line coming down here. I'm not sure what that is. If you have somebody that has pulmonary edema from CHF, one of the kind of classic patterns that they'll present with is what we call the bat wing pattern. So you notice you've got a little bit of air here, a little bit of air here, a little bit of air here, and a little bit of air here. That's kind of the classic pattern. A lot of times they're going to develop from that back to this where it's really widespread. But it just depends on the patient as well. So what do we think is going on here? So looking, I've got really good lung markings on this side, good costophrenic angle. One thing that does stand out to me is I've got a little bit of tracheal shift. So my trachea is kind of shoved over this way. And then I've got nothing on this side. So what do we think that is? Could be a lot of different things. In this patient, it's somebody that's had a pneumonectomy. So if you get a chest x-ray like this, hopefully you talk to your patient beforehand. But go look, see if they have any sort of scars. Sometimes our patients are awake and can tell us, sometimes they can't. It's really embarrassing when you intubate somebody and you don't have breath sounds on one side and you didn't realize that they'd already had a pneumonectomy. This is a patient that's got an aneurysm of their aortic arch. So it's kind of easy to distinguish here versus the one I talked about earlier where you just had a wide mediastinum. So see how large the aorta is here? It's pretty easy to tell that he's either got a tumor sitting there or his aortic's that wide. Again, patient history may help with that, or a lateral view. Somebody with cardiomegaly, look how large that heart is. It takes up well over 50% of the cardiac or of the thoracic distance. So one of the things that we run into with radiologists is they spend a lot of time pointing out the obvious to us, but they also will not commit to things. So you will see what seems like a very clear diagnosis, send it off to a radiologist, and they'll come back, and their favorite thing to say is clinical correlation required. It's kind of like making a diagnosis but not committing to it. So just be cautious with radiologists and kind of what they will and won't say to you, even if it's really obvious. This is another example of an aortic dissection. You can follow the aortic arch around here, and you're able to make out how distended it is, how wide that mediastinum is. I butcher this every time, but the Chilaiditi sign occurs when you have a loop of intestine that gets caught between the diaphragm and the liver. So your liver is sitting here. This is our diaphragm, and you've got a loop of bowel that's actually sitting up above there. A lot of times this is asymptomatic and you just find it on chest x-rays, but sometimes what will happen is they come in with abdominal pain, they come in with difficulty breathing, and when you look, it looks like they have free air under the diaphragm. But if you pay a little bit more attention, you'll notice that this is more consistent with bowel. So you have air, but you have air inside the bowel as opposed to where you just had air under the diaphragm before. So Chilaiditi sign, maybe a totally innocent finding, or it may be the reason the patient's there. This is a patient with Boerhaave syndrome or Boerhaave's rupture. So they've got bi-based lunar infiltrates, large-scale aspiration, and they've got pneumomediastinum. You see the air around the heart there. Patients with Boerhaave syndrome tend to be extremely sick. From our standpoint, they usually require a thoracotomy. Because they are so sick, from a pulmonary standpoint, they're very difficult to manage. They're oftentimes septic as well. The mortality rate is pretty high for them. Patient with bilateral hilar adenopathy. So as you can see right there in the hilum, you've got a lot of fluid retention. So now we're just going to kind of look through a couple different chest x-rays and talk about some stuff. The big things I want you to retain from this lecture is what we've already talked about. These are just some examples to kind of go along with stuff. So this is a patient that presented with 35-year-old, difficulty breathing, unplanned weight loss over the last 3 months. So when you start hearing situations like that, a lot of times it'll present with an undiagnosed metastasis. So when I get a chest x-ray, lo and behold, he's got this kind of thin-walled cavitary lesion. Masses are generally going to be round. A lot of times I think of them as almost looking like golf balls. So that's a pretty classic presentation for that. One thing to be cautious of, especially in this area, make sure it's not somebody that already has a port placed, because a lot of the newer ports will present and they look like this kind of thin-walled lesion. 65-year-old that comes in with difficulty breathing for a month. He's got a little bit of fever, a little bit of productive cough. When we take a look at his chest x-ray here, we notice that he's got atelectasis on the left upper lobe. Notice how it's very anterior. And then you've got the unaffected lung is a little bit overinflated. So when you come over here and look, notice how it's kind of overinflated. It shifts the mediastinum over a little bit to make up for that loss of volume. 30-year-old female presents with a week of fever and cough. So kind of the nice thing here is we have not only an anterior view, but we also have a lateral view. And when we look, she's got right middle and left upper lobe pneumonia. So kind of a mixed picture for you there. But you're able to see it a little bit easier on the lateral view here and here. One thing to take into account from that lateral view, it may be hard to determine whether it's right or left side. So you kind of have to flip back and forth between your anterior view and your lateral view to help you out with that. It's a 28-year-old male inmate that comes in for CT-guided drainage of kind of a lesion there. And when you look, you've just got like a cavitary lesion here. A lot of times these patients will be kind of multi-procedure patients. So they may go to IR to start off with, and then they'll wind up going to the OR for a thoracotomy afterwards. Usually they'll wind up with a chest tube placed, but we tend to see them pretty quickly. And this is just an example of what you see with those cavitary lesions from the inside. They're pretty nasty. Not only do they generally look gross, but they pretty commonly smell bad too. So don't be surprised when they pop a scope in and you get that magnified picture. This is just an example of tuberculosis in a patient. Again, go back to your clinical picture. So this is somebody with emphysema. One of the things for you to think about there, we tend to kind of get these air trapping patterns here. Notice how you have soft tissue up here, and then you just have this large enhanced area of air trapping. The other thing that you'll commonly see is that because they do trap so much air there, they'll flatten the diaphragm out here. So instead of the diaphragm having that nice dome shape that we usually see, it's shoved everything down on that side. Over here, you can see it's still nice and curved with a good costophrenic angle. This is an example of what the lungs themselves look like. It's a good mental image for you. But notice that even though this is outside the body, these alveoli are still remaining inflated. So just think about the effect that has on your patient and their poor air exchange. So we take a look at this. This is somebody that has what appears to be a tumor, but what actually has happened here is that you've got a little bit of fluid that's collected in that fissure on that right side. This is very hard to distinguish. You can't tell the difference between fluid and soft tissue a lot of times on a film. They're going to have kind of the same density. So this may be somebody that benefits from getting a CT or getting a positioning change as well. So we take a look here. We've got kind of a weird pattern. We're not sure what's going on. The right side there, it looks like maybe we've got a pneumonia down in this kind of right lower lobe. It's a little bit easier to see on that lateral view. So this is somebody with that pulmonary edema. If you take a look here, we have very prominent vascular or pulmonary markings because they've got all that fluid that's trapped in there. Other things that play into it, the large size of the heart as well. Think about your clinical picture. Same patient, before and after they were diuresed. So it's kind of nice when you see things improve like that. So this is just a lesion off the chest wall. Notice that it's off the wall itself, not the lung. Really doesn't make a huge difference for us other than the fact that the lung may not be affected by the disease process, other than the fact that you're going to have some compression of that lung. You're probably also going to have some irritation because of the kind of it rubs back and forth there. This is what I was talking about as far as fluid. Not the classic pattern that you would see with somebody in an upright position, but you've got cardiac structure coming down here. You've obviously lost your costophrenic angle here. I can still make it out on this side, but this is an example of like a chylothorax here. You may also get all sorts of weird things that are collected in lungs. Sometimes it's blood, sometimes it's fluid, sometimes it's cholesterol. So try and stay away from those things. They're kind of gross. It's a patient with a large lung mass. You can make out here. Like I said, they always kind of remind me of a golf ball. They're almost always round. And then this is just an example of what it looks like on the inside. Somebody with kind of a small pneumothorax up here. So if I look on this side, I'm able to see my pulmonary markings coming all the way out. When I come over here, it's not nearly as obvious as the chest x-ray we looked at earlier where this whole side was gone, but you can see how the lung has slowly been pushed down there. So I've got air trapping up here and then the lung has been forced down. Again, think about your presentation. Somebody with a right middle lobe pneumothorax. So one thing to think about is your patient positioning. If they're upright, obviously I anticipate the air being trapped up here. This is probably somebody laying supine. And you can see how I've got good lung markings, good lung markings, good lung markings, and then I've kind of got this black hole in the middle here as the air's been trapped. Somebody like this, I would be a little concerned that the air didn't spread out. So you may see that there's some sort of compliance issue, or not necessarily compliance issue, some sort of elasticity issue that's prevented that air from traveling and being trapped right there. So you may see that's like somebody with emphysema. Maybe they had like a bulla that ruptured there, something like that. They got a chest tube put in, everything re-expanded. This is somebody with metastatic disease. Notice how you've got all these nodules throughout the chest. Probably not a real great situation for them. Kind of a weird nodule here. You just got this one kind of sitting up in the right upper lobe. Another example of TBE. Another example of kind of a perihilar mass in somebody with Hodgkin's lymphoma. This is a patient with a wide mediastinum. Notice how you've even got a little bit of tracheal deviation there, or rotation, but very large mediastinal area there. Somebody with PA stenosis, you may not detect that, but one thing that is kind of weird is how large that pulmonary vasculature is. And then when you take a look at their heart, you'll notice that they've got a little bit of cardiomegaly there, probably due to the stenosis itself. So that's what I have. What questions do you guys have?
Could you point out some of the pulmonary markings with the air trapping again? I was having a hard time seeing that.
You're talking about like with somebody with a pneumothorax?
Yes, with that one.
Yeah, let me go pop back to one.
I don't know why, I just couldn't see the pulmonary markings there.
Chest x-rays do not show up very well on pictures. Some are a little bit better than others, but so this is an example of it. So when you look here, notice how you're able to see kind of on this side, the pulmonary markings coming all the way out, these kind of faint lines. You can't make it out quite as well on this side. Right here in kind of the perihilar area, you can see pulmonary markings there, but notice how it's gone entirely in that kind of air-filled space there. Let me see, there was another one back here. This one's a little bit easier to see, a little bit better image quality. So on the right side, you can follow these pulmonary markings all the way up into the apex. On the left side here, I've got some, but I don't have them carrying all the way up. And then I have this kind of area where the lung has been shoved down by the air trapping up here in the new apex. There's one more back here somewhere that was a little easier.
In your opinion, is it better to look at chest x-rays for pneumothorax, or ultrasound's more reliable?
It depends on what you have. So you have to think about kind of the setting. Most of the time in the operating room, it takes a couple minutes to get somebody in there with a C-arm to get a picture for you. The ultrasound tends to be a little bit easier to get into kind of use. The other thing is it really depends on the overall clinical picture. If I've got somebody that I'm thinking they've got a pneumothorax, I may intervene even before I get imaging, especially if it's clinically significant. But I generally go to ultrasound faster, just because from a logistical standpoint, I can get it to me faster. This is another pneumothorax example. On the right side here, you can see your pulmonary markings kind of traveling all the way out the side. On the left side, it's very obvious that the pulmonary markings are limited. I can see where the lung volume has been decreased, and then I've got that very air-filled space beside it. But like I said, it really just depends on what you have available to you and what you can get quickly. Say, for instance, you were doing like a portacath, you may already have the ultrasound in there. You may even have the C-arm in there. So if I can just kind of move the C-arm up and look at the chest, I will. Lots of times, those patients or those that are high risk for pneumothorax, they're going to want to get a chest x-ray on them anyways. Some places in the ICU, you have to get a chest x-ray before you can use the line. That doesn't usually carry over to the operating room. Vivian asked if we needed to know all these pictures towards the end. No, I really want you guys just to be familiar with things that you need to know from an anesthesia standpoint. So big things: CHF, COPD, pneumothorax, hemothorax, basic chest x-ray anatomy, cardiomegaly, and then placement of ET tubes and lines and that sort of thing. Megan asked about resources for looking at practice chest x-rays. I'll put an announcement up there with a couple different web links that I think are pretty helpful for them. There's one called Radiopedia that's pretty good for looking at all sorts of different radiologic imaging. And then there's another one that I'm pretty sure I put in the readings. It's kind of helpful too. I'll make sure it's there real quick. No, it's not there. I'll add it. I'll send out an announcement with it. Some of them kind of have practice for you. Jessica asked, how can we differentiate air trapping from pneumothorax versus COPD emphysema? So air trapping and COPD emphysema are generally going to be the same thing. The air trapping is going to happen because of the emphysema. That's where you wind up with like the bulla and the alveoli remaining inflated. So that's generally going to be a widespread problem. The pneumothorax is generally going to be localized. And the other difference is when you look at that chest x-ray, if you have somebody that's got a pneumothorax, a lot of times you're going to lose those lung volumes. So you won't have lung markings, you won't have vascular markings because that whole tissue area has been displaced by the pneumothorax. So if you're able to follow it out, usually you'll see that those lungs go all the way out to the edge of the chest, whereas with somebody with a pneumothorax, it's not going to happen that way. Whether it's an axillary pneumothorax or an apical pneumothorax, usually you're going to see that those lung volumes have been lost because of that. All right, anybody have any other questions?
Hey, can you hear me, Dr. C?
Do what?
Can you hear me?
Yeah.
Yeah, my regard was, what are you looking for when you, like, say we've got someone under general and all of a sudden you're suspecting, what are you looking for sign-wise? I mean, I know that like kind of obvious things with like SATs and stuff like that, but like, are you looking more at your volumes, or are you just?
And you're suspecting a pneumothorax?
Yeah.
So first thing I would think about, what could have caused it? The obvious thing is like, I did a block somewhere near the lungs, put a central line in, they're putting a port in. Maybe it's a trauma patient. Maybe it's somebody that's got bad COPD. So first thing's kind of either a mechanism or an index of suspicion that would be consistent with pneumothorax, because that's kind of gets me thinking. Next thing I'm going to look at is, do I know what their baseline was? So do I know what my tidal volumes were? Do I know what my airway pressures were? Do I know what my pulse ox was? And then I'm going to start to look for changes from that. Sometimes under anesthesia, you kind of have to, work through things. So biggest things that I start thinking about as far as the pneumothorax, increased oxygen demand. So maybe when they got in there, their SAT was like 98, 99 on 50%. Now over time, their SAT has trended down and I've had to go up on the oxygen. Simultaneously, you'll see that a lot of times your airway pressures will go up. Depending on how you're ventilating affects, whether it's going to be a pressure increase or a volume increase. So say, for instance, I've got somebody on like pressure control of 30, and I'm getting tidal volumes of 500 initially. Now, I'm still maintaining that pressure control of 30, but my volumes are going to start to drop off with that same pressure. On the other hand, if I'm doing volume ventilation, I may see that my airway pressures are going up to maintain that same volume. So that kind of affects that perspective as far as whether it's like an increase in pressure or an increase in volume. You can always check your breath sounds. Under anesthesia, a lot of times it's kind of hard to tell. I would encourage you to turn the ventilator off, hand ventilate them. But it's really like a cumulative picture. Other things that come into play, patient history. If I'm seeing those things happening and I've got a patient with a history of asthma, it may be that I assume that it's probably some sort of bronchial reaction as opposed to a pneumothorax. So you kind of have to look at the big picture and just work through things. If I'm thinking it's asthma and I give that patient a neb treatment and it gets better, it's probably asthma. I mean, that may have helped a little bit because they had a little bit of reactive airway disease and I dilated those bronchioles, but they could still have a pneumothorax too. We know that pulmonary disease predisposes you to pneumothorax. So it's kind of hard to just like have one thing and this is your go-to. It's really, you kind of start working through things methodologically and figure out what works.
Okay. Yeah. So just troubleshoot.
Yeah. Just troubleshoot it, try one thing, see what happens. There's not like one magic answer for it. Yeah. Do you have a question, Destiny? maybe not. Jackson said in regards to research, yes, a total of 225 for ACLS, PALS, and BLS. All right. Any other questions? Okay. Just to kind of review, like I said, a lot of those pictures on the back end, I don't expect you to worry about all those tumors and those sorts of things. It's more just weird things that you'll see. Kind of wanted to expose you to those. Really just think about the things that either affect us or that we have control over. So, free air into the diaphragm, tube and line placement, pneumothorax, hemothorax. Those sorts of things are the big stuff I want you to think about. Wide mediastinum on a chest x-ray. Those things. All right. Well, that's what I've got for today. If anybody